Hello, my name is Saqib Rahman, and I'm a trainee in upper gastrointestinal surgery and a research fellow for the RCS and University of Southampton. Today, I'm going to be talking about a body of work being undertaken with the Clinical Effectiveness Unit at the Royal College of Surgeons of England. ProgROC, Prediction of Outcomes and Prognosis of Radical Treatment in Oesophagogastric Cancer. I myself have been supported by the RCS with a one-year research fellowship in conjunction with the Rosetree Trust, which allowed me to take time out of clinical practice to perform this research. And I've also been supported by some of the main surgical professional organisations to conduct this, including the Association of Upper Gastrointestinal Surgery, the British Association of Surgical Oncology, and the Surgical Research Society, along with the National Oesophagogastric Cancer Audit, with whom the research was actually conducted. I'm extremely grateful to all of these organisations, without whom this research project would not have been possible. So my research is primarily regarding cancer of the esophagus or gullet. Esophageal cancer is the 7th most common cause of cancer death in the UK, and we have the unenviable title of having the highest rate of one type, adenocarcinoma, in the world for this cancer. Only just over a third of patients are curable when they present, with the remaining 2/3 only suitable for palliative treatment. For patients that we can cure, we usually offer surgery to remove the esophagus, and that operation is a huge thing to have done, with up to 2/3 of patients suffering a complication of surgery, 1/3 a major complication, and it's probably something that takes a year or more to recover from. And of those patients who undergo that massive procedure, only a half will live for 5 years. And yet we have a poor understanding of which patients any of these things happen to. Who will live long term, who won't, who gets on well with surgery, who doesn't. This research project is about trying to address some of these issues using national level data from England and Wales. We have been analysing the National Oesophagogastric Cancer Audit, or NOGCA, which is run by the Clinical Effectiveness Unit of the Royal College of Surgeons of England, and is a compulsory audit of all patients diagnosed with esophageal or gastric cancer since 2012. The journeys of some 70,000 patients are recorded there, of whom about 15,000 have had surgery, making it probably the largest database of these patients in the world. We sourced data from the Office of National Statistics and other data sets to make it more robust, and we looked at how machine learning could be used to predict survival after treatment, and if we can anticipate who might suffer complications of surgery. The machine learning aspects I find really interesting, as it's something that's been underutilized in clinical fields up to now, leveraging the number crunching abilities of modern computers to try and help our decision making better. The details of machine learning is beyond the scope of this talk, but what they do is allow a much more flexible approach to considering variables and how they interact with one another than otherwise you could do, which in theory means that you can predict better what will happen in the future and gain novel insights into the underlying biological processes. So what have we achieved so far? We have derived personalised prediction tools for survival for patients with esophageal and gastric cancers in excess of anything else that exists. And we've used those to gain some new insights about disease processes, and we've turned them into free-to-use online models that have been published in important surgical journals. We've prototyped online dashboards for complication tracking and outcome monitoring, and we're currently working on predicting complications prior to surgery, although that's proving to be a bit tricky. We've also gone sideways and using some of the methods developed in the NOGCA dataset to look at other data, including how image analysis of diagnostic biopsies and radiology images might be integrated into automated outcome prediction. Although this is fairly early in development, we've yielded some intriguing results. In summary, the RCS Fellowship has allowed us to develop a suite of tools for patients with esophageal cancer that hopefully will lead to better prediction of outcomes in this patient group, and ultimately to the better decision-making and care. And once again, I'd like to thank the RCS for the opportunity, and to you for your attention. My email address is on the slide if anyone would like to contact me and ask them a question.